Thanks, Adrian, and thank you very much for the invitation to speak today, and thank you, Bianca, for your beautiful presentation. It's so lovely to hear the voice of young people, and really we all know that that's what it's all about, really, isn't it? Seeing the lives of young people impacted and the trajectory of where they're heading, you know, to see them to be successful young adults in their life. So just a bit of background, I work at the Children's Hospital at Westmead, and we have got a service for children and adolescents who are affected by drugs and alcohol. It's called CICADA. So we offer care and intervention for this group of children and adolescents, and we've got 3 streams to the service. The first stream is a fetal alcohol spectrum disorder assessment clinic. We have a family service that work with children of parents who are using substances, drugs and alcohol, and also an adolescent service. And I suppose the interest and unique thing about collaborating like this, it's really a life spectrum approach, a lifespan approach, because we know that drugs and alcohol can affect us all in at any stage of our life. But when you think about the lives of children, it can be prenatal exposure, it can be early life exposure, can be exposure during childhood, which obviously we know that can cause some significant outcomes, poor outcomes for children if they're exposed to neglect or abuse or domestic violence, etc. But also adolescent service, because we know that adolescence is really the peak time of initiation to substance use, and as Bianca said so beautifully, if we can intervene with young people, as well in early adolescence, how much we may be able to prevent. So just in the next few minutes, I'll try and keep to time. I'm going to talk about the importance of early intervention, but really I suppose my interest is that early adolescence, early and mid-adolescence, which is the average age of the kids that we see. I'm going to talk about the role of a paediatrician, because really it's probably over the last 10 years or so, things are changing. Paediatrics or paediatric hospitals traditionally have not had drug and alcohol services, but I know our culture is actually changing to look at the impact of substance use on children and young people, and how we work in a holistic and developmental approach. And we had an interesting question earlier about, is it important really to understand the developmental age of adolescents? And I would say yes, most definitely, because a 12-year-old or a 13-year-old is very different to a 17-year-old who's very different to a 20-year-old. Really, if you think about what's going on in their, physical development, with early puberty, with their cognitive development, with their social maturation going from, primary school to high school and early adulthood and college, etc. I'll talk a little bit more about the model of care that we use, and really how the importance of making the most of every opportunity. Young people, in essence, think of themselves as healthy. Young people don't often seek help, and somebody else made a comment that I think it was the Weave presentation, or Kirkton Road. It was when we were talking about young adults accessing Kirkton Road. Often they've been using, illicit substances or polysubstance use for a number of years before they access treatment, and they're the young people of that service. So how we can, make the most of every opportunity with young people. And I'm going to talk about some of the stories of the teenagers that we see at the hospital. So really, we have touched on this, and it's, I think, understanding the maturational change that happens in adolescence. We know that puberty, is the beginning of adolescence, and that's happening 9, 10, with physical changes and hormonal changes in the body, but also there's cognitive changes. And we've had 20 years of knowledge now of understanding that the maturation in the brain, is continuing right up into the mid-20s, and that maturation starts in the occipital lobe, ends in the frontal lobe. So that executive function, higher level thinking, impulse control, etc., is really progressing on into late adolescence and early adulthood. And there is this. I'll show you this little. I don't know if I've got a pointer, but the graph here, which shows the synaptic refinement and receptors and blood flow in the brain from prenatal to post-birth age, when you see that block of adolescence, there's a nice peak of the synaptic refinement. We call it pruning. You know, the brain is undergoing a number of changes where you've got synaptic refinement. You've had a stage of synaptic proliferation as the brain is growing, but in adolescence we call it the use it or lose it, you know. The environment and what the activities of the young people are really helping develop and impact on their brain development. And when we've had a lot of communication talking about substance use in adolescence, and we know that the peak age of initiation is really in that early adolescence. Michelle, in her talk this morning, gave some statistics about 18, 19 being the average age of use of illicit substances, but actually there is a cohort of kids who are not actually in. The data isn't captured in the school surveys because they're not attending schools. That are that high risk and vulnerable group, and that's the group that I suppose we're really interested in and worried about. So if you think about it, what is the importance of, what is the impact of early onset alcohol use? Well, we've got more and more data that is coming out and research that shows that early onset alcohol use really does increase the risk of problematic use in later adolescence and early adulthood, including binge drinking. It increases the risk by 4-fold of alcohol dependence in adulthood. It increases the risk most definitely of anxiety, depression and conduct disorder, and increases the risk of other illicit substances. And I'm sure your friend would agree that heavy alcohol use is consistently associated with suicide risk. And I think he mentioned about that relationship with the risk of suicide is really evident. So when you think about the adolescent brain, we imaging studies now show that heavy drinking can lead to reducing volume of the hippocampus in the brain, and that impacts on learning and memory. When you talk to young people when they've had this pattern of binge drinking, they talk a lot about their memory, and that's one of the things that they're often worried about. So that binge drinking episode doesn't just affect their school learning the next day or so, but it can continue on for a number of days, if not a week after, just after one binge. So imaging studies have shown poor brain activity during a memory task. And you've seen that image up there, the 15-year-old male heavy drinker, which has minimal of that pink highlighted, which is a functional study when they're doing a memory task. So what about cannabis use? I hope you like my picture there. I think I stole it from Graham Pringle 10 or so years ago, actually. Where is Graham? I said to Graham that he's the one who's got me into this, really, as well as receiving a fellowship through the New South Wales Health. But when I was working in adolescent health, in the youth health setting, being exposed to young people with substance use kind of triggered my interest in this area. But we know that young people, the earlier they smoke cannabis and the heavier they're smoking, the higher risk for impaired attention, impaired memory, increased risk for anxiety, increased risk for depression and psychosis. And we know that there's a bi-directional relationship with those mental health comorbidities. So young people who have a risk of psychosis or depression are more likely to use substances, and young people who are using substances early are more likely to have the comorbid mental health issues. What about methamphetamine use? We've seen the graphs that were presented this morning of increased presentations to the emergency departments of young people and all ages really with methamphetamine use. But we know that earlier onset of methamphetamine use increases the risk again for mental illness, depression, suicidal ideation. But it's that antisocial behaviour and crime, risky sexual activity and unwanted sexual activity, or maybe not planned sexual activity. And also really when you're thinking of early adolescence and mid-adolescence and late adolescence, you're really thinking about child protection issues. If you've got a 13, 14, 15-year-old who's using methamphetamine, the issue is not really about the drugs, but it's about the big picture, what's going on for this child and looking at keeping them safe. So yes, it's about the adolescent brain, it's about the impact on their development and their growth and learning, but it's also the harms associated. So young people, it's interesting because I work as a paediatrician and I work very closely with adult addiction medicine colleagues who work with patients who have had many years and chronic relapsing, dependence, substance use dependence. That's often not the case for adolescents, but it's the harms associated that we get very concerned about. young people who are involved in car accidents or motor vehicle accidents where they've been under the influence of drugs or alcohol, or the driver has been under the influence of drugs or alcohol, obviously increasing morbidity and mortality, violence, as I said, unsafe sexual practices and risk of sexual assault, victimisation, increased risk of polysubstance use. The psychological harms, dropping out of school. If we think about kids, if they don't, achieve education, where that's going to lead them, into their adulthood, but also risk of substance dependence. And then those social and interpersonal relationships, family conflict, homelessness. So many young people, adolescents that we see are running away from home, family conflict, and substance use increases the risk for that, and criminal activity. So when we look at adolescent health or adolescent interventions, we look at risk and protective factors. And I'm sure you're all very familiar with this, but we work on building resilience in young people, because if, despite the background and despite the trauma or whatever's been going on, if you can be resilient and have the ability to bounce back from those harms, then you can do okay in life. But when we look at the risk factors for substance use, we kind of break them up in what's happening individually. Is there issues with impulsivity? What are the personality characteristics or traits? Is there mental illness? What's going on with the family? Is there parental substance use? Is there, substance use in the community? Who are the peers that this person's hanging out with? What about school? Is there a learning difficulty? Is there bullying going on at school? What's going on with their social media? Often we ask the kids, show us your feed. What's going on? What are you filling your mind with all the time? What's going on with their peers and the community? Is there a lot of aggression or violence in their peers, exposure to domestic violence, etc.? So if we can build, our intervention really is building on those protective factors, so just flipping them, the opposite. If there's problems with the individual risk factors, building on, their sense of confidence, their sense of well-being, their sense of, even building in, what is their belief system? Their sense of morale? What's going on with the family? And family therapy, as we've already heard this morning, is one of those things that actually is evidence-based and worked, and multidimensional family therapy is something you've got to work with the parents and the family or the carers around a young person. They're not in isolation of their family. And what's going on with their attachment? Is there issues there? The school, can we do anything to help this young person re-engage in school? Working with our colleagues in the education system, and the peer and community. Sometimes it's about creating a new peer group, helping these kids connect with peers who are a positive influence. And that's where working with, NGO organisations and mentor programs and things like that is really key. So what about trauma? When we look at adolescents and those in early adolescence who are using substances, often all of those risk factors that I talked about can bring early life trauma and childhood trauma. But it then increases that risk for using substances. But then when you've got a teenager who's using methamphetamine, cannabis use, who's running away from home, who's out on the streets, then it increases the risk of traumatic events happening to them and exposure to violence or other harms. And so it's this vicious cycle. And in our clinic, we do, I was just talking to Emma Barrett from NDARC, who's got a real interest in research in trauma with young people with comorbid substance use. But we do screening on our kids and that we see in our adolescent clinic, and I would say 90% of them have multiple complex traumas that they've experienced, that are impacting in some way, and many of them have PTSD symptoms, not all, but many. And so it's really, as someone offering intervention, being trauma-informed, being understanding and having that approach, working with a young person, understanding how that impacts them. And really, trauma can impact the developmental stage of an adolescent. It can affect their emotion and behaviour control and emotion and behaviour regulation. You put your hand up if you've got teenagers, or if you've seen teenagers. A normal healthy teenager is going on the ups and downs with their hormones and puberty and all of the normal teenage things. Add trauma onto that and add substance use onto that. Really getting a grasp of being able to regulate your emotion and behaviour is really tough for these kids. Often trauma can disconnect them from their social groups, their families. Often often it fragments their identity. And in late adolescence, it's really about who am I, where am I going, what am I doing, what's my purpose to life? That's all the questions that are going on for young people. Where do I fit in this big world, and how am I negotiating my purpose in life? And trauma can really impact that. It can impact the externalising behaviours, and as we talked about, just that more access to risk as well. So really, it's building on the resilience. The flip side of that is building resilience in young people and how we do that in a holistic way. So we've already touched on this, but there's a number of vulnerable groups, and really a lot of young people have many more, more than one of these factors that increase their vulnerability to substance use. Many young people have intellectual disability that have actually not been diagnosed, particularly if they've dropped out of school or not been engaged for a long time or had behavioural difficulties. Many young people have the parental substance use, and I suppose at our hospital that's why we have a service which really has a lifespan approach, looking at, well, was there prenatal alcohol exposure? Was there early life exposure to drugs and alcohol? If your mum and dad are using, then it increases your likelihood of that's your norm if that's in your community. Young people in out-of-home care, we've got a big cohort of kids in New South Wales, particularly out in the west where our hospital is, of kids who are in group homes and out-of-home care, and they're a very vulnerable group. And of course kids who are involved in juvenile detention. So this is the latest, some statistics from the latest Young People in Custody Health Survey that was only published a few months ago actually, but a fifth of the kids in juvenile detention have been in out-of-home care. Half of them have had a parent in prison. 3/4 of them not attending school, 13% homeless, 50% have had an exposure to traumatic event. 18% had an extremely low IQ, 40% IQ was in the borderline range. So these kids, have got complex levels of difficulties. 85% previously been in custody, so that's a big problem, isn't it? These kids, there's just a revolving door, of going into custody, coming out, and going back into custody again. But when you look at their substance use, substance use of kids in custody, 90% have ever been drunk, but almost 40% on a weekly basis. 92% have tried illicit substances, and 80% on a weekly basis, and most of those were intoxicated at the time of the crime. Cannabis, methamphetamine, MDMA, cocaine, so cannabis being the number one, but more and more methamphetamine use. So suppose the question is, what do we do? So as Adrian said, I'm a paediatrician. I've also worked had training in addiction medicine, but what is the approach for young people? With the College of Physicians now, there's adolescent and young adult medicine training, which is addition for paediatricians and also adult physicians and other doctors to train specifically in working with that young people, that second decade of life, 10 to 20, where there is a real difference in their developmental trajectory. So understanding, is it early adolescence, middle, late adolescence, what's going on for the young person? Engaging them. Young people have to feel connected. They have to feel listened to. They have to feel heard. They have to feel like, well, what's the main issue for them? Maybe their parents dragged them in. Maybe they have court mandated. Maybe they've come in because of some sort of crisis. But their main issue may be different to, their care or their worker or their parents, issue of what they are working on. So focusing on prevention, early intervention, and also the prevention of harms. And so really being able to do a risk assessment on this young person. What's going on for them? What are the risks? What are the harms? And then treating them really in the light of their family, school and community. So keeping the main thing. So working out what is the main thing for this young person. So this is our hospital, and we see kids who come in through the emergency department, who come in through our mental health unit, kids who have chronic illness, who come in, through many other health services, who have substance use. And so we're quite proactive and assertive in our approach, I suppose, because understanding that kids don't necessarily come and say, I want some help for my drugs, some of them do. But if you can capture a 14-year-old and say, hey, how are the drugs working with you at the moment? What's going on for you? How can we help? Then we like to engage them around that. And it might not be the first time, might not be the second time, might be the third or fourth time that we see them, that we start to make some progress. So what about hospital presentations? So Michelle presented some data about ED presentations across the state, but I must say, I think it really depends on the emergency department doctors. Do they identify if there is substance use? Do they identify? It's easy, really, if the young person comes in with alcohol intoxication or maybe with a drug-induced psychosis. That's an easy, way of labelling and presenting and identifying substance use. But what if they've come in with injury because they've, got a metacarpal injury because they've smashed something because they were angry because they were withdrawing from cannabis? What if they've come in with a motor vehicle accident because they were drunk, or their dad was drunk, or the driver of the vehicle was polysubstance using? What if they came in with mental health issues, cutting or behavioural disturbance, and they've got polysubstance use but the doctors haven't asked about that? So really it's the primary reasons and the secondary reasons of coming to hospital. So really I suppose my belief is that hospital presentations associated with adolescent substance use really provide a unique opportunity for developmentally appropriate early intervention. And we talked, Yifra presented a little bit about brief interventions, and we know that certainly brief interventions for adults with tobacco use has got good evidence. Brief interventions for alcohol and other drug use in adolescents shows some evidence for reduction in drug and alcohol use, and I agree with the concept that your assessment can be an intervention, and we take that very much seriously. Often we see a young person once, and that assessment time is also intervention, because we don't know if we're going to see them again or not. But we do know that sometimes opportunities are missed, and it's really because maybe paediatricians or doctors or this can go for GPs or psychiatrists as well. Maybe there is a lack of knowledge or a lack of confidence in understanding the impact of substance use on a young person, or what to do with that, or where to send them, or where to go for help. So we really, if we think about the HEADS assessment, I'm sure you're all familiar with a psychosocial model of assessing young people, looking at what's going on in the home, in their education, with their eating, exercise, activities, looking at depression or drugs, and what's going on with their sleep and safety. If we look at that assessment for young people through the eyes of what's going on with their substance use, and how does their substance use impact all of these things. So I just thought I'd talk to you about a few stories of kids that we've seen. Kids, there you go, Yifra, I've used the same word. Kids who have come through our emergency department and how we work with them. So these are not their real names and not their real photos, but I just thought I'd give you a little snapshot of the type of young people that we see. Because I think listening to the stories of young people and learning from them is really key, isn't it? How can we work with these kids? So this is Noel. He was 13 years old. He was homeless. He actually came to us as an outpatient, through the outpatient referred through youth health service, and he presented wanting some help for his substance use. He wanted some help for his cannabis use and methamphetamine use. But at the time of presentation, he was under the care of the Family and Community Services, living in a hotel with carers from an NGO, looking after him. They were on roster, they were on shift, and they brought this kid to a youth health service to have assessment. So he was seen by one of the GPs there and referred to our service for his substance use. But he's 13, is not engaged with school and hasn't been for a very long time. So he's pretty much year seven and not engaged. But he does have a background of learning difficulties and has been seen by a paediatrician in his growing up years. And he was diagnosed with ADHD when he was young, but his dad stopped his medication because he didn't like the effect, didn't like his kid being on medication. However, he's living with his father most of the time, and his father ended up going into detention for his own reasons. And Noel went under the radar. He was pretty much living by himself, and then started using methamphetamine, being on the streets, and was picked up that way. So methamphetamine for him was actually protective, keeping him awake, keeping him safe on the streets to a degree, until things kind of spiralled downwards. It wasn't just methamphetamine, cannabis use also. So what do we do with a kid like this? It's not just an easy thing, is it? It's not just about the drugs, it's not just about, methamphetamine use and what else is going on. Really, go back to that slide, keep the main thing the main thing. So the main thing is really stable home environment for this kid, you know. He actually lived in a hotel for a number of weeks and kept absconding. You know, the carers, of course, they were lovely and engaged with him, but turned their back and he was off. And really he kept going back to his home and community, although family and community services deemed that to be an unsafe environment for him. It wasn't until his dad was released from detention did they kind of soften things a little bit and find a cousin for him to stay with. Once he got a stable environment, after our third, fourth trial of connecting with this young boy, he came and required some treatment, was happy to have treatment for his ADHD. And this kid was impulsive, inattentive, couldn't sit still for more than 2 seconds, difficult to engage. He'd already been in detention, juvenile detention, twice in that time frame of a month from the first time I saw him and had the referral to when we were able to connect with him regarding his ADHD. Started him on some medication. For that, he became a new kid. Really able to stay at home, able to follow instructions, able to connect, keeping out of criminal activity, and has remained abstinent from his drugs. Particularly the methamphetamine. And now we're in the process of re-engaging him with school. And a mainstream school is not going to fit this kid. Even a behaviour school is not going to fit this kid. So we've got to find something that can work closely with the Department of Education to find something that's a little bit outside the box that's going to work for him. And then go on to do some neurocognitive assessment to work out what is his learning level at, so that we can target things for him. We talked about goals, and the goal for this young boy is to be a landscaper. So it's, working with his hands and getting a mentor program. So that's our plan for him. And of course, treatment isn't just a few weeks, it's an ongoing thing because the risks are high, and engaging him. But step one, dealing with his, ADHD. What about Lara? So Lara's 14. She was diagnosed with diabetes when she was 10, but at a similar time she was removed from the care of her parents. She was placed in foster care, had a number of foster care placements, and those placements broke down for various reasons, mostly related to her behaviour. At the time that we engaged her, she was 14. She was absconding from home multiple times, and of course every time she'd abscond from home, wouldn't take her insulin with her, wind up in hospital with complications related to that with DKA. And her compliance was particularly poor regarding her diabetes care, and the diabetes team were really struggling with how to engage this young girl. And her behaviours when she'd come back to the out-of-home care place were escalating with aggressive behaviours and violence, and police were being called, etc. And there was methamphetamine use. It took actually a little while to work out what was going on with this girl because she was very guarded about her substance use. So she had a number of presentations for medical reasons, behavioural disturbance, self-harm and suicidal ideation, until as we were able to piece information together and working with family and community services and her out-of-home care workers, realising that there's a lot of risky sexual behaviours and huge child protection issues for this girl, absconding, receiving drugs for free, and a lot of concerns for her. So the key for her really was a mental health admission in where we were able to contain her, help her cut down the substance use, but actually contain her to a point of diagnosing a anxiety disorder, doing neurocognitive assessment for this girl, realising that even though she was very street savvy, understanding that she had quite a low IQ, and then her treatment was tweaked or changed to be able to address the needs for her at the level of her IQ. And then engagement was the key for her, engaging her with her diabetes team, and she was very fortunate to have two very committed family community services workers who had travelled with her right up until she's now in independent living, has moved from the out-of-home care. So I've only got a few more minutes, but I'm going to talk to you about Eve. Eve's 15. She'd had 3 presentations to our emergency department in a month, mostly mental health kind of presentations with behavioural disturbance, polypharmacy overdose and self-harm. She referred to mental health services but never engaged. Had a previous admission for 2 months to mental health but actually didn't engage after that also. And her substance use was increasing. Cannabis use daily, methamphetamine use, cocaine use, inhalant use as well. Really one of those girls who were very sensation-seeking. If you look at their personality type, sensation-seeking, looking for the fun in things. We engaged her parents, actually. She was a young girl who was adopted, but in a loving family. A lot of her underlying issues were around her attachment and identity, and this was triggered by her trying to connect with her biological mum. But we had a number of consultations with her parents and family to talk about substance use, to talk about containment, to talk about how, what may be going on with this girl. And we've just started engaging her after being connected with the Juvenile Justice Service, but working with her JJO, engaging her in treatment, dealing with her, she's got a drug-induced psychosis, having some medication for that, and starting to engage her what's important for her. So that's the key in, engaging her with motivational enhancement, therapy and CBT, and her current stage of change is not interested. But I said, well, what is it, Eve? What's the things? What are your main goals? Her main goals are less conflict at home, not needing to rely on the weed in order to keep calm at home, and not being aggressive with my friends, and so keeping away from the police. So working with the young person and their goals, and a lot of, as we've talked about already, case coordination. It's not just a one person who helps these kids, it's a team and big community and multidisciplinary approach. Okay, I think I've got a couple more minutes. I'm going to just tell you about Jazz. She's 15. She presented to our emergency department and was highlighted through our child protection services after a sexual assault. Again, this story of absconding from home, family discord, mum with alcohol dependence and a lot of issues related to that. She had substance use for that short period of time where she was on the streets and absconding and sexual risk-taking behaviour. We were able to engage this young girl alongside with our child protection services, working together with them, doing both and being trauma informed. This young girl has had a significant trauma, and addressing the trauma issues as well as the underlying depression, and engaging her extended family, grandma, who's the key adult in her life. Okay, I think I'm running short of time. Should I tell you about Dave as well? So Dave's 14. He presented unconscious after being found at school, and they thought it was a head injury, unconscious to the emergency department, but it was actually there was no story of head injury. It was alcohol intoxication, drunk half a bottle of vodka when he was at school and then found collapsed. But interestingly, this kid has a background of neonatal abstinence syndrome, where it needed, mum was on the methadone program when he was born, and he had that NAS syndrome, maternal drug and alcohol use. So although he was with his biological mum for a number of years and extended family, he's been in foster care since 9 years of age. And at school, there's a lot of bullying going on. He'd previously had neurocognitive assessment and found to have a lower IQ, but was never actually addressed at school. So not actually getting any additional assistance for his learning difficulties. And he also was diagnosed with autistic spectrum and ADHD, but neither of those were addressed or being treated. So he was targeted at school and targeted and being bullied, and didn't have the ability to refuse when other kids are engaging him with this risky behaviour. So, the intervention for him is, talking about psychoeducation and some refusal skills, engaging mentor service for him, completing the developmental assessment, and really with that thought, is there a fetal alcohol spectrum disorder with this kid? And so, the alcohol exposure prenatally, how has that affected him? And recently, this is just a plug for the Australian guidelines to diagnosis of fetal alcohol spectrum disorder. It's only recently been assessed. You probably can't see that, but when there's prenatal alcohol exposure, if you confirm that, there's a number of domains in the neurocognitive domains which need to be assessed, and the kids may or may not have sentinel facial features of FASD. But there's a number of domains, including brainal structure, motor skills, cognition, language, memory, attention, executive function, which and affect regulation and adaptive behaviour, leading down to that autistic spectrum. All of these areas can be impacted by the effects of prenatal alcohol exposure. And so identifying this in young people, I think, can be helpful. Although he didn't have the sentinel facial features, certainly the prenatal alcohol exposure and cognitive impairment needs to be in the first to third percentile in order to make a diagnosis. So this kid, meets the criteria. So framing his disability, I suppose, really, for both school, his carer, and potentially for his future, to be able to get supports as a young adult, when he moves out of the foster care environment. So being a paediatrician, having an adolescent approach, working in developmental framework, engaging young people, focusing on prevention, early intervention, looking at the harms, doing a risk assessment and treating the young person in the light of their home, school, community. Our model of care is working with not only health, adolescent medicine, child protection services, our mental health colleagues, working closely with our emergency departments and the mental health CNCs who are on the cold face, working with kids who are coming in with being at risk, working with our drug health colleagues and the whole of family teams, looking at at-risk young people, and then non-government organisations that are around and how we can, referring out to the community for that additional community support. We've kind of talked about that. So really, the question is new generation, new approaches. Well, I'd say yes, maybe, but also some of the age-old approaches of engaging young people, listening to them, hearing their voice, working out what's the main thing for them. We talked already about what's their needs and what's their wants, and being there for the long haul for them, I think, are all the keys. So I hope you have enjoyed that, but I just think if we're going to make the most of every opportunity with that early adolescent group so that we can try and offer hope, to change the trajectory for them that could potentially help them reach their full potential in life. Thanks.